Welcome, curious minds, to another deep dive, and welcome to Drug of the Week, presented by the Book Podcaster. This week, we're cutting through the noise, really getting into a medication you're almost definitely going to see. In clinical settings, maybe even on your nursing state board exams, Pantoprazole.
That's right.
You probably know it as Protonix, maybe Pantoloc or Tecta.
Mm-hmm.
It's not just some random pill. It's a super common proton pump inhibitor. Really key for things like GERD, ulcers, and that GI prophylaxis you see a lot in hospitalized patients.
Yeah, inpatient, outpatient, it's everywhere.
Exactly. So it's incredibly relevant to your practice.
Absolutely. And our mission today is really to bring down pantoprazole. We want to give you those like aha moments, connecting the textbook stuff to what you actually do.
Right.
We'll look at its classification, how it really works, its uses, and probably most importantly, the critical stuff. Precautions, side effects, how to give it safely. That's key for patient safety and just effective care.
Okay, let's dive in then. Let's get to the core of pantoprazole. So first things first, for anyone maybe newer to this, how do we classify it? Where does it fit?
Okay, so pharmacologically, its job description basically is a proton pump inhibitor, a PPI.
PPI.
Think of it like a very specific gatekeeper for acid production. And then therapeutically, what it does for the patient, we call it an anti-ulcer agent.
Anti-ulcer agent, okay.
So that kind of dual identity really sums up its main function. Control stomach acid to heal or prevent ulcers.
Control stomach acid. I
Oh,
like
yeah.
that. So how does it actually do that? Is it just like mopping up the acid, or is it more precise? What's the mechanism?
It's actually fascinatingly precise. It doesn't just, neutralize the acid that's already there.
Oh.
Instead, it directly binds to a specific enzyme. And it does this when the stomach is highly acidic, right where you need the action.
So it waits for the right conditions.
Exactly. Think of it like a key that only works in a very specific lock the enzyme and only in that acidic environment. And this binding is critical because it stops the final step, the final transport of hydrogen ions into the stomach lumen.
Hydrogen ions. Those are the building blocks of acid, right?
Precisely. So basically, it's stopping acid production right at the source. It's turning off the pump.
Wow. Okay. So not just cleaning up, like you said, but actually turning off the faucet. That sounds pretty powerful. What does that mean for the patient practically?
Exactly. The result is, way less acid building up in the stomach, which means less acid reflux, huge for people with GUR. You also see healing of things like duodenal ulcers and esophagitis, inflammation in the esophagus from reflux.
Right.
And it really clamps down on acid secretion in those hypersecretory conditions where the stomach's just making way too much acid, like Zollinger-Ellison syndrome.
Okay, Zollinger-Ellison, got it.
Yeah.
So when would a doctor or prescriber typically reach for pantoprazole? What are the main conditions it's indicated for?
It's definitely a go-to for several things where acid suppression is the goal. The big one is probably erosive esophagitis that's linked to GERD. It helps heal that damage from chronic reflux.
Okay.
And it's also used for the maintenance of healing for that same condition. Super important to prevent it coming back.
Right. Maintenance therapy.
Yeah. And then you've got those pathologic hypersecretory conditions we mentioned, with Zollinger-Ellison being the classic example, where you just need serious acid control.
Are there any, less common uses? Maybe something off-label, but still important to know about?
Yes, definitely. There's a pretty significant unlabeled use you'll see in practice. It can be used as part of the treatment for duodenal ulcers when they're associated with Helicobacter pylori.
Ah, H. pylori.
The bacteria.
Exactly. So pantoprazole helps calm down that acidic environment while the other drugs, usually antibiotics, go after the bacteria itself.
Okay, that makes sense. So we know what it is, what it's for. Now, how does the body actually, handle it once it's in the system?
Yeah.
Absorption, metabolism, that kind of thing. Yeah, so a few interesting points about its journey. If you're taking the tablet, it's enteric-coated.
Enteric-coated. Why is that important?
It's crucial because it means absorption doesn't happen until after it leaves the stomach. It protects the drug from being broken down by all that stomach acid too early. Then, once it's absorbed, it's mostly metabolized in the liver by two main enzymes, CYP2C19 and CYP3A4.
Ah, the CYP enzymes. Okay, this is where genetics can play a role, right? I know that affects how people handle different drugs. Does that happen with pantoprazole?
It absolutely does. And this is really critical for thinking about individual patients. That CYP2C19 enzyme shows genetic polymorphism.
Polymorphism meaning variation.
Exactly. It means a fair number of people, like maybe 15–20% of Asian patients and 3–5% of white and black patients, might be what we call poor metabolizers.
Okay, poor metabolizers. So what does that mean for them if they take pantoprazole?
Well, for those individuals, the drug levels in their body can get significantly higher than expected.
Oh, okay. More drug hanging around?
Yeah. Right. Which leads to a higher risk of side effects. It really underlines why, one-size-fits-all dosing doesn't always work. We need to consider these individual factors.
That's a really important point. So after it's metabolized, how does the body get rid of it?
The inactive metabolites mostly leave through the urine, about 71%, and some in the feces, around 18%. The half-life itself is pretty short, only about an hour.
Only an hour. But I thought the effects lasted longer.
Right, that's the key thing. The half-life doesn't tell the whole story about how long it suppresses acid.
Okay, so how quickly does it start working on the acid, and how long does that effect actually stick around?
Well, the route you give it makes a big difference. If you take it orally, PO, you'll typically see a decent effect, maybe 51% acid inhibition around 2.5 hours later.
2.5 hours, okay.
But here's the interesting part. That acid-lowering effect can actually linger for up to a week after someone stops taking it.
A week? Wow.
Yeah. Now, if you give it intravenously, IV, it's much faster. Onset is usually within like 15 to 30 minutes.
Much quicker.
And the peak effect hits around 2 hours. That speed is why IV is often used in the hospital when you need to get that acid down fast.
Right. Makes sense. Okay, this brings us to a really, really important area. Given how common this drug is, what are the red flags, the critical warnings, potential bad reactions? What do patients and healthcare professionals absolutely need to be watching out for?
Yeah, patient safety is huge here. First off, it's an absolute contraindication, a definite no-go if someone has a known hypersensitivity to pantoprazole itself or related drugs like other benzimidazoles.
Okay, so allergies are key. What about using it long-term? You hear concerns about that with PPI sometimes. Are there specific precautions?
You're right to ask. There are definitely some important precautions, especially with long-term use. For example, patients on high doses for more than a year, they have an increased risk of fractures hip, wrist, or spine.
Fractures, okay.
And we also sometimes see fundic gland polyps. These are usually small, benign growths in the stomach lining that can develop with prolonged use.
Anything else with long-term?
Yes. Therapy for more than 3 years raises the risk of vitamin B12 deficiency.
Ah, B12. Good to know.
And we need to watch electrolytes. There's a risk of low calcium, hypocalcemia, especially after about 3 months of treatment, and also zinc deficiency, particularly if someone's getting it IV.
Okay, so B12, calcium, zinc. Lot to track. What about specific groups like pregnant women, kids, older folks?
Absolutely critical considerations. For pregnancy and lactation, it's really a risk-benefit discussion. Only use it if the potential benefit to the mother clearly outweighs any potential risk to the fetus or infant.
Makes sense.
In pediatrics, well, safety and effectiveness just haven't really been established for kids under certain ages for different things. Like, it's generally not used for hypersecretory conditions if they're under 18 or for oral erosive esophagitis under 5.
So limited use in kids. What about older adults?
Right, older adults. This is a big one. Pantoprazole is actually on the Beers list.
Beers list. That flags potentially inappropriate meds for seniors, right?
Exactly. For older adults, there's an increased risk of clostridioids, difficile infection C. diff, or CDD.
Oh, CD diff is serious.
Very. And also increased risk of pneumonia, GI malignancies, bone loss, and those fractures we mentioned. Because of all this, scheduled use for more than 8 weeks should generally be avoided in older adults unless they're really high risk, like maybe on chronic steroids or NSAIDs, or have specific conditions like erosive esophagitis that truly require it. It's definitely not a drug to just keep them on indefinitely without good reason.
Wow, okay. That's a really important heads up for geriatric care. So moving from precautions to actual adverse reactions, what side effects might someone actually experience? What should we be vigilant for?
We need to be watching for a whole range, some quite rare but very serious. Like on the skin, you need to be aware of potential severe skin reactions, things like Stevens-Johnson syndrome, toxic epidermal neutrolysis.
Oh, those are really bad.
Extremely serious. Any kind of unusual spreading rash is an immediate red flag. Stop the drug, get help.
Okay. What about more common things, maybe GI related?
Yeah, GI-wise, watch for abdominal pain, diarrhea. And this isn't just, mild diarrhea. It could be that life-threatening CDA we mentioned.
Right, C. diff again.
And the really tricky thing is CDA can show up even weeks after they've stopped taking the pantoprazole.
Weeks later? Wow.
Yeah, so persistent diarrhea needs investigation. Other less severe GI things can be like burping gas.
Okay. And beyond the gut.
Well, we talked about those electrolyte imbalances, low calcium, low potassium, low magnesium, especially with treatment longer than 3 months. And remember that vitamin B12 deficiency risk with long-term use.
Got it.
Other things that can pop up include headache, maybe hyperglycemia, and potentially serious, though rare, things like acute kidney problems, tubular interstitial nephritis or systemic lupus, and of course, generalized hypersensitivity like anaphylaxis or angioedema.
Okay, quite a list. Given all that, what about interactions? What other drugs might clash with pantoprazole?
Drug interactions are definitely something to be careful about. One really critical one is with certain antiretrovirals used for HIV, like atazanavir and nelfinavir.
How do they interact?
Pantoprazole can seriously decrease their levels and effectiveness, so using them together should generally be avoided. That's a major one to remember.
Okay, avoid with certain HIV meds. What else? You mentioned it changes stomach acid. Does that affect other drugs?
You're exactly right. Because it lowers stomach acid, it can mess with the absorption of drugs that need an acidic environment to be absorbed properly.
Ah, like what kinds of drugs?
Things like certain antifungals, ketoconazole, itraconazole, some antibiotics like ampicillin esters, even iron supplements, or some important meds like erlotinib, which is used for cancer, or mycophenolate mofetil, used after transplants.
Wow, okay, so it can reduce their effect.
Potentially, yes. Couple other big interactions. It might increase the risk of bleeding if someone's taking warfarin.
Oh, warfarin. Need to watch that closely.
Absolutely monitor their INRPT very carefully. And remember how pantoprazole can lower magnesium and potassium?
Yeah.
Well, those low levels can increase the risk of digoxin toxicity.
Ah, okay, another interaction loop.
Exactly. And one more, it might increase methotrexate levels and the risk of its toxicity. So the bottom line is you always need a thorough medication review for any patient starting pantoprazole.
Definitely highlights the importance of med reconciliation. Okay, let's shift to practical application. How do we actually give pantoprazole, and what are the key nursing points? The things we need to do at the bedside?
Right. This is where the rubber meets the road for safe care. First, a quick but really important confusion warning. Don't mix up Protonix with Lotronex or Protamine. Sound alike, look alike errors happen.
Good point. Always double check.
Always. Second, if a patient is on IV pantoprazole, the goal should always be to switch them to the oral PO form as soon as they can tolerate it. Usually within about 7 days. It's safer, cheaper, just better if possible.
Makes sense. So for PO administration, what are the specifics? Any common mistakes?
For oral, the timing is key.
Yeah.
Give it 30 to 60 minutes before meal, ideally before breakfast.
For food. Got it.
If it's twice a day, then first dose before breakfast, second dose before dinner. And this is crucial. Tell patients to swallow the tablets whole. Do not break, crush, or chew.
Don't crush. Why again?
That enteric coating, it needs to stay intact to protect the drug from stomach acid and ensure it gets absorbed in the right place.
Okay. What about the suspension?
Right, the oral suspension granules, they have very specific instructions. You sprinkle them on applesauce or mix them with apple juice. Only those two things.
Applesauce or apple juice only?
Yes. And swallow immediately. Don't save it. Same goes for giving it via NG or G tube. Use apple juice. No other liquids or foods. But antacids can be used at the same time if needed.
Okay. And AVI administration. Sounds like that might need more care.
IV administration definitely requires precision. Whether you're doing an IV push or an intermittent infusion, you first reconstitute the vial, usually with 0.9% normal saline.
Okay.
For an IV push, you give it undiluted, but slowly, over at least 2 minutes.
Over 2 minutes. Slow push.
Right. For an intermittent infusion, you dilute it further, and the amount of dilution actually varies depending on the patient's age, so check that, and then you infuse it over 15 minutes.
15 minutes for infusion.
Yep. The big takeaway for IV is always double-check your facility's protocol or a reliable drug reference for the exact steps. Reconstitution, dilution, rate. Details matter hugely here.
Absolutely. And what about Y-site compatibility? Always a headache in a busy unit.
Oh, it's vital. Pantoprazole has a list of things it's compatible with and things it's definitely not compatible with through the same Y site. Like, it might be okay with ampicillin or azithromycin, but not with cefepime or levofloxacin, for example.
So you can't just assume.
Never assume. You must consult a comprehensive, up-to-date compatibility chart every single time. Mixing incompatible drugs can cause precipitates, block lines, and activate meds. It's dangerous.
Good warning. Okay, beyond just giving the drug, what assessments should we be doing? What needs monitoring?
You need to routinely assess for any epigastric or abdominal pain. Check for signs of GI bleeding, any blood, obvious or hidden, in stool, vomit, or NG tube drainage.
Okay.
Monitor bowel function really closely. Remember that CD risk? So, report diarrhea, cramping, fever, bloody stools immediately.
Yeah.
Even if it seems mild, especially if it persists.
Right, and especially with that delayed onset risk.
Exactly. If they're getting an IV, check the injection site for signs of thrombophlebitis, redness, pain, swelling, and always assess for any signs of hypersensitivity reaction, trouble breathing, hives, rash. If you see that, stop the drug immediately and notify the provider.
Okay. What about labs?
Lab-wise, keep an eye on liver function tests, AST, ALT, alk-phos, bilirubin. Crucially, monitor serum, magnesium, and calcium levels before starting and periodically during therapy.
Magnesium, calcium, check.
Especially if they're on it for a while, or getting other drugs that can affect those electrolytes. For long-term use, check vitamin B12 levels, and with IV use, monitor zinc levels.
Okay, that covers assessment. Finally, patient teaching. What do patients and their families need to know when they go home with this?
Patient education is absolutely key for safe use at home. First, make sure they understand why they're taking it and the potential side effects. Tell them to read the info sheet that comes with it.
Okay.
Stress that they need to take it exactly as directed for the full course, even if they start feeling better. So common for people to stop early once the heartburn's gone.
Right. Need the full course for healing.
Exactly. Advise them to tell their doctor or pharmacist about all their meds prescriptions, OTCs, vitamins, herbals, before starting anything new because of those interactions we talked about.
Good point.
Counsel them to try and avoid alcohol, aspirin, NSAIDs if possible, and any foods that seem to trigger their symptoms. And tell them to report serious signs right away: black, tarry stools, persistent diarrhea, severe abdominal pain.
And what about treating diarrhea themselves?
That's crucial. Tell them, do not treat diarrhea with over-the-counter antidiarrheals without talking to their healthcare provider first, especially because of that C. diff risk.
Okay, call first.
Yes. And for women who could become pregnant, advise them to let their provider know if they're planning pregnancy, suspect they are pregnant, or if they're breastfeeding.
Got it. So ultimately, what are we hoping to achieve with pantoprazole? What's the main goal?
The main goal, the desired outcome, is really diminished acid in the stomach, less reflux, healing of any ulcers or esophagitis, and decreased acid production in those hypersecretory states. It's about getting that GI system back in balance.
Wow. Okay, that was incredibly thorough. A real deep dive into pantoprazole, from how it works so precisely down to those really important long-term risks and all the details about giving it safely. It's really clear why understanding this med is so important, whether you're studying for exams or working directly with patients.
Absolutely. The complexity is there, isn't it? The interactions, the different considerations for different people. It really hammers home why we need to be vigilant, why monitoring and good patient teaching are just non-negotiable. Knowing the why behind it all is what leads to safer, better care.
Yeah, this breakdown has definitely given us, and hopefully you listening, a much clearer picture of pantoprazole, both its benefits and its challenges. It really is a cornerstone medication.
It is. And, connecting this back, it kind of raises an interesting question for you to think about. We talked about how pantoprazole is so targeted, right? It specifically binds that enzyme to block acid. So how might that one very focused action end up causing ripples elsewhere in the body? How does blocking acid production lead to things like potential bone density issues or that vitamin B12 deficiency we discussed over the long term?
Wow.
What does that tell us about how interconnected everything is in our bodies? How even a really targeted intervention can have these, well, sometimes surprising, far-reaching effects?
That's definitely something to chew on, thinking about those downstream effects. Great food for thought as you navigate your own learning and clinical practice. Hopefully this breakdown of pantoprazole helps you feel more confident, whether you're facing exams or caring for patients. And don't forget to like, comment, and subscribe so you never miss our weekly medication breakdown from Drug of the Week. Thanks for diving deep with us.